My name is Rishi Gupta. I'm the co-director of neurosciences at the Wellstar Health Systems in Marietta, Georgia. I'm also an interventional neurologist. I will be presenting the ASSIST registry, which is a registry sponsored by Stryker looking at operator techniques in treating acute ischemic stroke, large vessel occlusion. The ASSIST registry was designed to identify the best operator technique for mechanical thrombectomy in acute ischemic stroke. It was presented at the International Stroke Conference by my colleague, Dr. Liebskind. And I would like to go over the results of this study, which is a pivotal study, which will hopefully help clinicians and operators performing mechanical thrombectomy for stroke. So the design of this study was a global multi-center prospective consecutive enrollment registry, and it's critical to highlight the multi-center global nature of this study, as there were 71 enrolling sites from Asia, Europe, and North America, which included 1,300 patients with large vessel occlusion. So this first analysis is with these 1,300 patients. There are 200 additional patients who underwent direct aspiration with large bore Vecta catheters who will be added for the 1,500 subject final count, which will be presented at a later date. The primary endpoint for this was to assess for procedural success, which we define as first pass, TICI 2C or 3, clinical outcomes, as with all clinical trials, of a modified Rankin of 0 to 2 at 90 days, and safety endpoints, including intracranial hemorrhage complications, as well as any vessel injury from the techniques that we are studying in this study. The methods of this are the Stryker device was used in all of these buckets as the first pass. And it's also important to highlight that these were core lab adjudicated by Dr. Liebskind at UCLA. And so the three buckets that we were assessing are, the first was the Stent Retriever Classic, and the Stent Retriever Classic entails a Trevo device to engage the clot with a balloon guide catheter in the carotid artery. The Stent Retriever Combination was the arm with an aspiration catheter plus the Trevo device at the site of the thrombus, in combination with either a long guide sheath or a balloon guide catheter. And the final bucket was a direct aspiration with either the Catalyst or the Vecta aspiration catheters. And as I mentioned earlier, 200 subjects of the Vecta line will be added to the direct aspiration in a later analysis. So this is the three buckets, just to give you the full setup of the three techniques that were used in the trial. And again, I want to highlight that the Trevo Retriever was a stent retriever in the SR Classic and SR Combination. In SR Combination, there was a balloon guide or the Infinity guide catheter, which is a non-balloon guide. So this allowed analysis, as you will see, a balloon guide versus non-balloon guide, as well as comparing these three buckets to each other to see if there was a superior technique in terms of first pass effect. So the inclusion criteria for this trial were patients who presented with an acute ischemic stroke secondary to a large vessel occlusion in the anterior circulation. So this did not include the vertebro-basilar system. The signed informed consent by a LAR or the patient if available. And the intended treatment technique was one of these three buckets that were defined a priori. The exclusion criteria was patients could not be participating in another device or clinical trial. So one of the things that is really critical to highlight of this trial is it has a flavor of a cluster type analysis. As you know, many device/operator technique trials can be very challenging to perform, but one of the ways to sort of get around this hurdle is robust site selection. And in order to do this, it was imperative that each site who participated had a tremendous evidence of research experience along with operator experience with the preferred technique. So a survey was sent to each site. Each site chose the technique that they would participate in, and this was done in order to avoid bias so that different sites were not doing different techniques that they were unfamiliar with. These were the primary techniques at each site. So we felt that this would allow every effort to ensure that the thrombectomy technique being employed was actually the best technique in the hands of that operator. So I know there will be a lot of criticisms of operator experience and operator technique, but please acknowledge that these were sites that this was their primary technique. There was also rigorous enrollment containment measures to maintain uniformity and ensure there's balance across each technique and each site, as you'll see as we go through these slides. So this primary analysis presented today is of the 1,300 subjects that were enrolled in the ASSIST registry. The first enrollment was in January of 2019, and the last patient enrolled in January of 2022. So it's been a 3-year journey to enroll all of these patients. And so I think some of the highlights of this, as you can see, with such a large number of subjects, there was 100% procedure data, fully sourced data verified by a CRO that went on site to and remotely to verify all the data through source documents. So that's over 3 million data points that were 100% verified. So a tremendous amount of data was acquired in this study. There were 216 monitoring visits completed with over 3,400 hours spent on monitoring data alone. And informed consent could be done retroactively, but within 48 hours. We acknowledge this can be a point of bias in this trial, and we will discuss that as a limitation later. 99% of subject imaging and angiography was available, and you can see the number of queries were over 24,000. So I think this is a tremendous data source and a heavy lift by Stryker as well as their CRO to do this study. And so we have to acknowledge, and congratulate the sponsor of this study for a tremendous lift to get this data. So as you can see, here were sort of the site enrollments. You can see there was representation from Asia, Europe, and North America. So a broad swath. 539 patients were enrolled in the United States. And you can see the European countries involved as well as South Korea from Asia. So, it's sort of a good sort of heterogeneity of patients across the globe. So what were the outcomes we were looking at? So from the clinical outcome standpoint, as consistent with most clinical trials in stroke, the primary endpoint was good functional outcome, a Rankin of 0 to 2 at 90 days. We also had secondary analysis looking at excellent functional outcomes, Rankin 0 to 1 at 90 days. And another key component of this, because it's a technical operator technique study, was to look at early response. And so this is defined as NIH stroke scale improvement at 10 or more points from their baseline that they were admitted with. The primary endpoint of the study from a procedural standpoint was the E-TICI 2C or greater on the first pass, as adjudicated by the core lab, not by the site. And this is critical because, as many of you know, core lab adjudication typically is more rigorous than site adjudication. And so it tends to be a little bit lower TICI 2C or 3 with core lab adjudication. So that's critical here. We also looked at secondary endpoints of first pass effect with TICI 2B 50 or greater, and also time points of the procedure, as well as achieving TICI 2B or greater with first pass and final pass of the procedure. And then the safety endpoints are, as with every stroke trial, mortality, symptomatic intracranial hemorrhage, any device-related injury or procedure-related injury. And I think one thing that's important for a device sort of an operator technique trial is to look at ENT or embolization to a new territory as adjudicated by the core lab. So that's a critical piece of this study. So as you can see here, when we look at the demographics, these are well-balanced arms, all 3 arms. There were no differences across age, sex, if TPA was used pre-treatment, and some of the traditional risk factors of diabetes, hyperlipidemia, which tells us this was a well-balanced study in terms of the number of patients allocated to each arm. When we look at their pre-stroke modified Rankin, again, there was no statistical difference across all arms. There was no statistical difference when we look at their baseline NIH stroke scale and the mode of presentation, if there's a wake-up stroke, a witnessed stroke, or an unwitnessed stroke. So again, balanced across 3 arms. When we look at the procedural details, as we get into the highlights of this, again, in the univariate modeling, there were no differences in clot location. So there was a slight higher note in the direct aspiration of carotid terminus, but it was not statistically significant, and I think that's important to highlight in the analysis here. The pre-procedure TICI score of 0 was equal at about 93% across all 3 arms, and general anesthesia was also more commonly used in the direct aspiration group over the other 2 stent retriever arms, but it was not statistically significant. So I think, again, this was balanced across demographics, clot location, pre-procedure TICI score, and mode of anesthesia used for this procedure. When we look at the times, so the time from last known normal to groin puncture was well balanced, 7.7 to 8.1 hour range. The number of passes to treat the target occlusion was statistically different. So there were more passes in the direct aspiration arm versus the stent retriever. And we'll talk about this a little bit more in depth at the end of this talk as to what this means. And the overall time to final reperfusion was roughly similar across all 3 arms, around 33 to 35 minutes. So when we look at the primary endpoint of TICI-2C or greater on the first pass, there was no statistical difference across the 3 buckets. SR Classic did have the higher TICI-2C or greater first pass compared to the other 2 buckets, but it was not statistically significant. I do want to highlight, based on historical controls, the 47.6% is higher than what's reported in the literature, and this is a core lab adjudicated trial. So it is important for future trials not to compare to historical controls, but to have contemporaneous cohorts that they're studying, because it's critical. As time has elapsed, we're seeing improvement in these scores, and this is likely related to operator techniques and operator experience. The other thing I want to highlight, which is interesting, which was not the primary endpoint of the study, but the TICI-3 on first pass was statistically significant, favoring SR Classic over SR combination and or direct aspiration. So you can see here that by quite a large margin, actually, there is a significant value for SR Classic for achieving TICI-3, which is perhaps surprising to many of my colleagues around the world, but I think it highlights the old technique still works, and I think that that's something we as a group need to understand. When we look at the TICI score at the end of the procedure, when we compare SR Classic to SR combination, it was statistically significant, and direct aspiration to combination was also statistically significant. Now, one of the things to be careful with this analysis, when we say end of procedure, there could have been crossover with end of procedure. This was not end of procedure with primary technique, and we will have that analysis later. It has not been fully vetted out yet, but I do think that will be critical, is to see at the end of the primary technique what the final TICI grade was, because I think that's what many of you are interested in. So I think this result of end of procedure is a little bit biased, because in the direct aspiration group, for instance, patients may have switched over to a different technique bucket to achieve that result. When we look at balloon guide, I know there's been a lot of discussion around balloon guide from registries such as NASA and the TRACK registry, and I think the one thing that is critical for everyone to see here is when a balloon guide was employed, it took longer for the procedure, and it was statistically significant versus non-balloon guide. So the use of balloon guide actually does delay care of patients. And what's also of interest, which again may be a surprise to many my colleagues around the world, is that it did not lead to higher first pass effect with balloon guide. As a matter of fact, when you go down the list here of TICI-2B50, TICI-2B67, and TICI-3, there was no statistical difference. And there was a statistical difference of TICI-2C, but it favored non-balloon guide. So overall, I think from a first pass effect, there was no difference with balloon guide. When we look at when we look at the final end of procedure TICI grades, there was a statistical significance favoring balloon guide over non-balloon guide in terms of end of procedure. Again, this needs to be flushed out a little bit more as we analyze the data in more depth to understand this phenomenon more, but you can see roughly 68.3% had TICI-2C or 3 in the balloon guide arm at the end of the procedure versus 66.6% in the non-balloon guide, and that is statistically significant. So I think there's a lot of work to do here to understand this better, but the first pass endpoint was not showing significance, and it did delay care to do a balloon guide. So when we look at outcomes, I think this is an interesting slide because we're seeing that there was no statistical difference in 90-day outcomes. And what's really encouraging, I think, for everybody in the field is that we're seeing upwards of 58% modified Rankin 0 to 2 in a real-world registry, excellent outcomes in the study across the board in all 3 arms. And I think that's kudos to everybody in the field for selecting patients as well as for the kinds of care that patients are receiving around the world. But I do think that the thing that what did strike us as investigators as interesting is when we break it down to early response proportion, you can see there's a trend favoring SR Classic for early response compared to the other 2 buckets. And this goes again, the first pass effect may be a marker of early response, but may not be as strong of a marker of 90-day Rankin, which is interesting because that's counter to what the literature currently says. Moreover, the first pass effect may be more linked to 90-day Rankin of excellent outcomes, because what we're seeing here is that the SR Classic had excellent outcomes that was statistically significant versus SR combination, and direct aspiration actually had excellent outcomes that was superior to SR combination. Again, one of the things we have to be careful here is this end of procedure reperfusion, or is this first pass effect? And we'll have the data soon, but my gut feeling in what I'm seeing from the analysis is it's end of procedure reperfusion, not first pass effect, that's leading to these outcomes because it seems more correlative to end of procedure. So I think what we're going to see when we have the final analysis, and that's why I put an asterisk here so we don't read into this too much, is that what we need to see is after primary technique is completed, what the outcomes look like in those arms, because I think we will be surprised by those results. When we look at all-cause mortality, there's no difference across the board. And we look at symptomatic intracranial hemorrhage, again, no differences. And ENT, no differences. So, again, what's remarkable in this study is if you look at the ENT rate for direct aspiration and stent retrievers, it was all under 1%. So again, when we look at the historical data, it was upwards of 3 to 4%. And so I think, again, comparing these kinds of things have to be done contemporaneously and not with historical controls. So I caution future investigators without a control arm. I think you may be misrepresenting the data. So what are the conclusions of the study? And I want to spend some time on kind of the high level of this trial, given that there are 200 more patients that will be analyzed and added at the end of the study as per protocol. So the first high level point I want to sort of ensure everybody understands is the SR Classic, the old traditional technique, had significantly higher first pass TICI-3 compared to the other 2 techniques. There's also a trend towards higher proportion of early response in terms of NIH stroke scale improvement at 10 or more points within the first 24 hours. So I think that is a shock to many people, but I do think that that's an interesting sort of finding, because when we think of it just simplistically, it's a simpler technique to put together in terms of time. With a combination, there are a lot more tools using a triaxial technique. So using all these different, as we put a balloon guide aspiration catheter, we start adding sort of to the tower of what we're doing, the time does elapse. But I think what we're finding with a simple balloon guide and a stent retriever, it seems like the first pass TICI-3 was significantly better. Combination therapies do take longer to achieve. So the more complexity you add to this, it does add more time to reperfusion. And we attribute this to lengthier times to set up for each pass is what I believe is occurring. And I think that's pragmatic to think that that's what's happening in the real world. Patients with direct aspiration, had higher number of passes compared to the stent retriever arms. And I think this is important because I think many people are going to come away with saying, well, the direct aspiration had similar outcomes to the stent retriever classic at the end of the day. I think we have to be careful because if many patients were in the direct aspiration were transferred over to stent retriever or crossed over to stent retriever, and that led to better outcomes, that's not a reflection of direct aspiration. So I'm going to put a big asterisk on number 3 because I think we need to have that data. And we also need to have the data of the larger bore catheters to know if this trend holds true. So I think many people will be interested to know what the 074 catheter line, what the impact of that is. So I think there's more to come along this. I think this is a good look at 1,300 patients for everyone to see that, one, outcomes are phenomenal across the world for thrombectomy. 2, stent retriever classic looks to be the first pass TICI-3 effect. 3, we're not sure if balloon guide really is improving outcomes, but it does cost some time to use it. And the first pass effect is something that we need to study a little bit more because I think everyone has ascribed that to be the gold standard. But I think the study is highlighting the first pass effect may not be as important as early reperfusion. So I think that's the part that we're going to highlight in the final paper is early reperfusion is probably linked to outcomes more than first pass effect. So those are the big key takeaways from this study. I know in talking to my colleagues around the world who have reached out about the trial, I think the limitations, as we can see from the study, are there was ability to retroactively consent patients and families up to 48 hours after the study. And I think we all acknowledge that does have its own inherent bias because one may say some of the bad outcomes were not included because they were not retroactively enrolled. So that is a definite limitation of the study. But being a sort of an operator technique study, I don't believe that impacts kind of globally what was going on with the technical aspect of what was happening. We may have seen a lower mortality rate than traditional studies as a result of that. The second thing is, I think, this can't be stressed enough. The primary technique by operator and site was a priori selected by those sites. This wasn't forcing operators to use a technique that they're not familiar with. So these are techniques that they're currently employing at their center today, and we clustered them to try to balance these clusters to get the best feel for best technique in the hands of best operators to see what we find. So I think one criticism of this study will be it's not generalizable to maybe smaller centers who may not be experts and maybe doing things that they're more comfortable with. I think one thing to take home from this, I understand that concern, but if a technique in expert hands is showing a higher rate of TICI-3, for example, favoring SR Classic, I would anticipate lower volume center operators would want to become proficient with a technique that has the higher chance of first pass TICI-3 as opposed to fighting off something and saying I'm not comfortable. So I think that's one other way to look at this is this kind of data may drive people to do what's actually the better technique, hopefully, and allow them to become more proficient with it as opposed to be reluctant or resistant to it. And then the last thing I want to highlight is that I think to run such a study is a tremendous sort of lift for the sponsor, Stryker, and I think they should be given kudos for what they've done here. This is an incredible data set. I think there will be a lot of sub-papers coming out of this, and I think we should acknowledge the amount of effort and work the company has put into getting this data. And I think for us clinicians, I think there's some highlights here that we can take home and better treat our patients with this data. As the paper comes out, I think many of you will be able to do a deeper dive into the data and analyze it for yourself. And as the subgroup analysis come out, I think there'll be some sort of rich data for everyone to dig into as well. So I'm hopeful this talk today will give a kind of a broader scope of what was presented at the International Stroke Conference by Dr. Liebskind. And I do want to thank my collaborators, Dr. Mullenbrook, who was a co-PI on the study, as well as Dr. Liebskind for presenting the data and being the core lab. I do think this was a tremendous effort by many, many physicians around the world. And I think it couldn't have been done without their generous ability to enroll in this study. I would like to thank Stryker for their tremendous effort in putting together the ASSIST registry and forwarding a tremendous amount of resources at a global scale to allow us to do this study. I would like to also thank my co-PI, Dr. Mullenbrook, for all of his efforts in helping analyze this data and putting the analysis together with me that was presented at the International Stroke Conference by Dr. Liebskein. I would also like to thank Dr. Liebskein for being the core lab and rapidly analyzing the data so we have it available to present to the community. And lastly, I would like to thank all the centers for their tremendous effort in enrolling in this study. I know it takes a lot of effort to go through the consent process and get all the data to the core lab, and this was a tremendous lift by all of you, and this couldn't have been done without you. So I'm proud of the results that have been put forth and look forward to the further analysis that will be put into the literature soon. Thank you very much.